This presentation is an analysis of a pharmacoeconomic article called Cost Effectiveness of Ceftolozane Tazobactam plus metronidazole compared with piperacillin tazobactam as empiric therapy for the treatment of complicated intra-abdominal infections based on the in vitro surveillance of bacterial isolates in the UK. Just to put a face to our names, my name is Mason and I'm presenting the introduction portion. Margaret will be presenting the methods, Katie will be presenting the discussion, and David will be presenting the conclusion. Starting off with the introduction, here are some clinical abbreviations we will be using throughout this presentation. Pip-tazo refers to piperacillin tazobactam. Ceftolozane refers to ceftolozane, tazobactam, and metronidazole. CIAI is a complicated intra-abdominal infection, and C. diff is a Clostridium difficile infection. So going back to the title does mention they are looking at cost effectiveness, but does not specifically state that this is a cost-utility analysis. The title could be improved by mentioning this is a CUA, or they are comparing the two medications in terms of quality-adjusted life years. The title does mention the comparators of ceftolozane and pip-tazo, and these are appropriate comparators clinically since they have similar spectrum of activities and are both commonly used to treat CIAIs. The disease is mentioned in the title as a CIAI. The one critique with this is the title does not mention they are looking at specifically gram-negative CIAI, which may be important for readers since roughly 30% of CIAI is gram-positive. The country is mentioned in the title as the UK, but the setting was not mentioned. The objective statement has been taken from the abstract of the article and reads, the objective of this study was to assess the cost-effectiveness of ceftolozane tazobactam and metronidazole compared with piperacillin tazobactam, commonly used in this indication, and the treatment of patients with CIAI in UK hospitals. This objective is clear and available in the abstract for readers who need a quick overview. As previously mentioned, the comparators are adequate and routinely used in clinical practice for this indication. However, the objective did not state that this was a Monte Carlo simulation and is looking at trends in data rather than real patients being enrolled in a study.
So now let's move on to the methods. Here are the clinical and economic inputs of the article, and you can see a more detailed list on the right in Table 2. In this article, this was a payer perspective as it focuses mostly on direct medical costs. There is no mention of indirect costs, and thus it's important to keep in mind that the results are not generalizable to patients. In terms of where they got the cost from, for hospitalization costs per day, this was from an NHS reference cost from 2013 to 2014. It was based on the cost of hospitalization stay of GI infection from a single intervention. It is good that the authors include the specific reference and years of where they got the cost so that the reader would be able to go back and reproduce a similar study. The article assumed that the disease progression of CIAI with both drugs would be similar. The article also assumed that the same therapeutic option would be utilized for both arms after culture results came back. As a result, the costs and benefits for this alternative therapy will be the same for both treatment arms, and thus it is appropriate that these costs and benefits are excluded from the analysis. The study appropriately included the drug acquisition costs only when the culture results were known because in clinical practice, the antibiotic may be discontinued or changed when the causative pathogen is known. Lastly, the cost of antibiotic preparation and administration, monitoring, and adverse events were excluded from the model. Alternative assumptions and inclusion of these parameters can potentially change the results of this pharmacoeconomic study. Just again, it is appropriate that the study did not take into account indirect costs since this is a payer perspective. The results may not be generalizable to patients since this is not from a societal perspective. The outcomes measured were quality-adjusted life years and total costs. One outcome was quality-adjusted life year, which is appropriate since the study is a cost-utility analysis. Since CIAI greatly impacts the quality of life of infected patients, it is appropriate for the authors to use a cost-utility analysis for the study and adjust the years of life based on utility. Quality-adjusted life years were discounted at a rate of 3.5% per year. The study did not apply the discount rate as costs occurred within the first year, since CIAI is an acute infection. The authors referenced where the discount rate came from, which again was good that they were transparent with the source. For quality-adjusted life year, the health utility for survivors is a study assumption at 0.85. The authors also state that this is a conservative measure and even references another study that is offered a health utility for survivors at 0.9. However, the authors do not include patient characteristics such as other comorbidities. So even though they're transparent with their utility score, not every patient has the same utility. For example, younger and healthier patients may have a higher utility score than older and sicker patients, so it is uncertain if the utility score is really appropriate for the patients in this study. It is worth noting that the study did include that 1,000 people were included in the study with an average age of 63.1 years and a range of 18 to 94 years old. Another assumption made by the study was that dose adjustments and bacterial resistance were assumed to be similar across the different treatments. This may be an issue since bacterial resistance can range between patients based on previously received antibiotics and other exposures. They did not mention this in the article as a potential negative impact. In addition, the study assumed that the proportion of gram-positive infections is 29.1%. A higher proportion of gram-positive pathogens is likely to make ceftolozane less cost-effective and increase the ICER, as the drug acquisition cost of ceftolozane is higher than that for pip/tazo. The assumption that we found the most worrisome on the surface from the study was that patients are either cured or die at the end of treatment. While it was good that the authors disclosed this assumption, there are a lot more complications that can occur and would change the costs of antibiotic treatment than the dichotomous outcomes of 100% cured and dead. However, after looking at this further, we also recognize that this is just a Monte Carlo simulation study, and the exact clinical outcomes of each patient is unknown, so it's appropriate for the author to assume an all or nothing outcome.
As Margaret mentioned, the main outcome was to determine which treatment option was the cost-effective option. It turned out that ceftolozane was the most cost-effective option. The cost per patient for ceftolozane was more expensive than pip/tazo, but the quality-adjusted life years were higher. When you look at the numbers themselves, it doesn't look like there is much of a difference, with the cost difference being €408 and the quality-adjusted life years being a difference of 0.1 years. However, when we calculated an ICER using the number highlighted in the box, the ICER we got was €4,080 per quality-adjusted life years. The authors described their ICER to be €4,350, and this article could have been improved by explaining where they received this number. Yet, since the authors use €4,350 in their sensitivity analyses, we will also be referencing this as the ICER throughout the rest of this presentation. For the sensitivity analyses, we believe that the authors did a very thorough job. Since this is a simulation model, the sensitivity analyses are especially important because there are so many variables that could impact the results of the study. The tornado chart is showing the influence that the different variables on the right have on the ICER, comparing ceftolozane versus pip/tazo. We believe that the authors included very relevant variables in an attempt to influence the ICER greatly. To highlight a few, they looked at reasons that could affect the length of stay in the hospital, resistance rates to both antibiotics, the health utility scores for survivors, and these are all very clinically relevant variables. The most influential variable was at the top of the tornado chart with the range listed out there in green. However, both of the costs, the $2,595 and the $7,063, are below the maximum willingness to pay threshold per NICE guidelines, which is $20,000 to $30,000. The authors also included a probabilistic sensitivity analysis, which is something that we want to see when an economic model study is provided. The chart to the left is a cost-effectiveness plane, and in the corner of the cost-effectiveness plane is an example of a chart you might be more familiar with. We are looking at the trade-off quadrant in the bigger picture. The dots are all of the differences in the cost between the two options based on the variables, and in every case, ceftolozane was cost-effective, but also more expensive than pip/tazo. On the right is the acceptability curve. So if you look at the point in the middle, the probability of ceftolozane was being cost-effective to pip/tazo at a willingness to pay threshold of $5,000 per quality of life adjusted life years was 67%. At willingness to pay of $10,000, the probability increases to 98.6% probability. So since the ICER range from the sensitivity analyses was about €2,500 to €7,000, you can see that the probability of ceftolozane being cost-effective is between about 30% and 85%. By providing these charts, the reader is able to make conclusions for themselves based on the variables that may be important to them from the previous tornado chart and make more specific assumptions than what the authors blankly state in the paper. So we think it is good that they included these as part of their study.
So now moving on discussing the results and the impact on clinical practice. CIAI caused significant morbidity. The authors state patients with CIAIs due to resistant pathogens are more likely to receive initially inappropriate antibiotic therapy. Studies cited within the article have shown that inappropriate therapy in gram-negative infection is associated with longer length of stay, higher hospital costs, and higher mortality rates. The CIAOW Complicated Intra-Abdominal Observational Worldwide Study was a worldwide observational study on complicated intra-abdominal infections conducted at 68 medical institutions during a 6-month period, from October 2012 to March 2013. 1,898 patients were enrolled with a mean age of 51.6 years. The Pharmacoeconomics article cites this study as reference number 11 and also uses it to rationalize the major pathogens in CIAIs and why the study assumes the rate of gram-positive pathogens to be 29.1%. CIAI is also the second most frequent infection in the ICU, so the need for appropriate antibiotic therapy is even more crucial. Because the study is a simulation model, several assumptions on clinical and economic inputs were made. The authors noted the many differences between the simulation model and what may actually occur in clinical practice. Several real-life variables were not accounted for in the simulation model. Therefore, the results of the study are proposed estimates, which should be interpreted with caution. However, the authors believe that the study is a good first step towards understanding the cost-effectiveness of ceftolozane and that further studies are needed, which we agree is an appropriate conclusion for them to make. Moving on to the study limitations, the pharmacoeconomic study is a simulation model again that assumes patients are either cured or die from the infection. The authors disclose that the clinical sequelae and complications of CIAI, such as severe sepsis, recurrent infections, and ICU transfer, may have significant economic costs. These additional costs were not considered in the study. The authors also state that they were not able to assess the risk of C. diff. C. diff is a known adverse effect of antibiotics. In a phase 3 study of ceftolozane/tazobactam, one patient out of 482 experienced C. diff. Exact rates of C. diff with pip/tazo are difficult to identify. While it is unknown whether the difference in rates between the antibiotics is significant, the possibility cannot be ruled out. And lastly on this slide, the model does not account for further treatment changes or costs of recurrence or readmission. As mentioned previously, clinicians and stakeholders cannot analyze patients as being simply cured or dead. The pharmacoeconomic study did not look at costs associated with future events, such as long-term complications and the impact on local or institutional antibiotic resistance. The model does not account for costs associated with fluid resuscitation, imaging such as CT/ultrasonography, or source control, like surgery, which are central components to the management of CIAI. Another limitation mentioned by the authors is that the model used one standard duration of therapy. Patients in the model received empiric antibiotic therapy for 3 days and then were observed for another 3 days. We agree with this limitation because many infectious guidelines recommend standard duration of therapy, which may be tailored based on a patient's age or risk category. Another limitation is that the model assumes each patient infection is caused by a single isolate, when in clinical practice it is possible for patients to have more than one isolate with their infection. However, for the purposes of this pharmacoeconomic article, we agree that it is still a good first step to understanding the economic impact of ceftolozane. And lastly, dose adjustments and changing bacterial resistance within each patient was not considered. The package insert of ceftolozane states that dose adjustments are needed in patients with moderately to severely impacted renal impairment. However, decreased efficacy has been observed in patients with a creatinine clearance of less than 50 mL per minute. Thus, these patient-specific factors would have affected the results of the study, and the authors did not look at patient-specific factors. Also, bacterial resistance within the patient is an important factor because the bacterial isolates may develop resistance over time, which changes the effectiveness of the study's antibiotics. While these are major assumptions to make, it was good that the authors disclosed these assumptions in great length, since they clearly would have a clinical impact on the results of the study if it was carried out in person. And for the conclusion, the authors had a few concluding remarks that we wanted to discuss. First, patient outcomes can be improved through the collection of local surveillance data and the use of local antibiograms in decision-making and guideline development. We feel that this is appropriate because the authors do not recommend the use of one agent over another, since a recommendation cannot be deduced from the results. Instead, the authors reinforce the benefit of antibiotic stewardship programs to improve patient outcomes and cost effectiveness. The next statement that they had was cost effectiveness of ceftolozane/tazobactam may be underestimated and not reflective of clinical practice. We feel that the cost effectiveness may be overstated since the model switches therapy to the lowest cost option. In clinical practice, clinicians may not be as cost conscious as the study authors. Instead, clinicians may want to focus on selecting the most appropriate antibiotic based on susceptibility values. The last concluding statement is gram-positive sequelae were not included since both treatment options are not indicated for gram-positive infections. We feel that this statement is both appropriate and inappropriate. Ceftolozane actually is indicated for treatment of CIAI caused by gram-positive pathogens in the US and UK. We acknowledge the fact that this study chose to only look at the gram-negative CIAI. However, we would have liked to see the authors acknowledge this fact and provide us with an analysis of any potential impact on the results. And the final slide that we have is the references used throughout this presentation.